pleasure to introduce the session transplant medication side effects. My name is Melinda Johnson, and my connection to pediatric transplant is I'm a mother of a boy who had a kidney transplant 4 years ago. We just passed the 4-year mark, and he is heading into his adult years. He just turned 17, so we're navigating that unknown territory. So I'm going to introduce our 3 presenters today. First, we have Dr. Mary Mas Chandran. She's a transplant pharmacist at the University of North Carolina Medical Center, caring for kidney, pancreas, and liver transplant recipients. Her main work is in the outpatient setting, where she follows patients long-term after transplant. She's passionate about helping transplant recipients make a successful transition from pediatric transplant care to adult transplant care as they become young adults. Then we will hear from Dr. Jessica Hoover. Dr. Hoover graduated from the Harrison School of Pharmacy at Auburn University. She went on to complete a residency at Bronson Methodist Hospital in Kalamazoo, Michigan, and a pediatric residency at Children's Memorial Hermann Hospital in Houston, Texas. She's currently practicing as a pediatric solid organ transplant clinical specialist at Cleveland Clinic Children's Hospital. In addition to her patient care responsibilities, she serves as the pediatric PGY2 residency program director and pediatric clinical coordinator. Then we will have Dr. Danielle Lazear. Dr. Lazear graduated from pharmacy school at the University of Kentucky and completed 2 years of residency at the University of Florida, where she specialized in pediatrics. She's been a clinical pharmacist at Cincinatti Children's Hospital for over 10 years, working with kidney, liver, and small bowel transplants throughout her time there. She now primarily works with the Division of Nephrology, managing patients with chronic kidney disease, dialysis, and kidney transplant. I will turn it over to Dr. Mary Mas Chandran.
Thank you very much, Melinda. It's a pleasure for us to all be here and speaking with you. So we're going to be talking today about transplant side effects with really a focus on the future long-term side effects, not necessarily what happens right after transplant, but what in the long term should we be thinking about. So to start with medication side effects, what a side effect is really an unwanted effect caused by medications. Typically, we think of these as being negative side effects or undesirable, but it really isn't. It's a love-hate relationship in that we need these medications. They're doing very important things for our patients, for our family members, our children, but they have these negative effects that kind of come with them. And so finding a way to marry those two can often be challenging, but is very important as well. We certainly don't want to expose anyone to anything more than they need to be in terms of a negative effect. And so it really is always a team effort to optimize medications and treatments for everyone. But that is, something we want to make you feel empowered and prepared to be able to do as you advocate for your children. So medications side effects can be scary. So we'll talk about that, but we do certainly have no intention of terrifying you today. Don't want to make things scary. Rather, we want to make you feel empowered. And so a lot of the information that we're going to provide today really is with the intent of making you feel as prepared as possible and as knowledgeable as possible with regard to medication side effects. And so one of the biggest things I want you to sort of take away is that take this information with you, but never feel like you should hold back. So let your providers and your transplant teams know if side effects are in fact occurring, any concerns that you're having so that those can be acted upon. So to make this a little more fun and interactive, we're going to play this or present this information in somewhat of the concept of a game, sort of Jeopardy style. So we'll say name that side effect. So we'll kind of talk about what those things are and then present what it is and come to that conclusion together. So first of all, the first one we'll talk about is how it presents. So the side effects you're going to likely see would be long-term chest pain. Worst case scenario, these things are heart attacks or strokes. Who this affects, So interestingly, the thing we're about to talk about is something that's the leading cause of death among adults in general. So transplant and non-transplant adults are going to have this side effect. What causes it? It's caused by plaques buildup in the blood vessels, or atherosclerosis is the official name for that. And then the biggest thing that I want to present for you today, and that the take-home point, is that preventing this side effect is possible, and the most important thing I want you to be aware of. And so the side effect that I'm in fact talking about is cardiovascular disease. Okay, so first one is, kind of leading into this, cardiovascular disease. So this is a disease of the heart and the blood vessels. And I'm putting some images up here for you to try to help make sense of all of this. So on the far right of the screen, you'll see the picture of a heart focused down in on blood vessels. At the top is a normal blood vessel where the little round red blood cells are happily floating to and from where they need to be. However, when plaques start to form, so you've heard probably the term atherosclerosis, it's these fatty plaques that form within the blood vessels. And as they start to build up within that blood vessel, the amount of room for red blood cells to float from one place to the other, from your heart, for example, to your brain, it becomes narrower, and it makes it harder for blood to get to where it needs to be, with the ultimate concern of if that plaque gets so large where it actually prevents the flow of blood, that's where we start to see these very negative events occurring. And so what those events are issues with either the heart or the brain or smaller blood vessels in the extremities of the body. So when you think of coronary heart disease, we worry about heart attacks, because if the blood can't get to the heart, it makes the heart essentially thirsty or hungry for oxygen, and we have cellular death. You can have it in cerebrovasculature, which is a fancy name for brain, and that can result as strokes. And then also you can have smaller blood vessels affected, where we see things like damage in the toes and the feet, and in instances like diabetic foot disease. So what is cardiovascular disease in terms of how much we should care about it? We should care a lot, because cardiovascular disease is a leading cause of death among adults. So in the general population, it occurs in 1 in 3 people, so about 30%. And in patients who've had a transplant, either as an adult transplant or a younger patient, it's about 1 in 2, so that goes up to 50%. The risk in transplant recipients that we're going to focus in on is that immunosuppression medications absolutely can play into this and add into that risk factor. So the medications you're likely familiar with seeing the names of that play into this are tacrolimus, cyclosporin, prednisone, sirolimus, and everolimus. So the name of the game with cardiovascular disease is prevention. We want to decrease risk as much as we can. We certainly know we have to take some of those medications. So what are the risk factors that are within all of our control and our children's control, and what can we help them do to avoid long-term risk? And so many of the things are going to sound very common and familiar to you. So first things are avoiding smoking, limiting alcohol abuse, and then generally just overall healthy lifestyle. So healthy weight, maintaining normal blood pressure, normal blood cholesterol, avoiding diabetes or treating diabetes if it's present, being physically active, and having a balanced diet. So all things we all know are important and try to do regularly. So then let's break that down a little more and look at some side effects within the cardiovascular disease realm. So first one, or the next one, will be elevated blood pressure reading, something I'm sure you've all seen or are familiar with. Who it affects? It affects most transplant patients. So anywhere from 50 to 80% of patients who've had a transplant can have elevated blood pressures. What's it caused by? Lots of things. So genetics, medications, and lifestyle choices. And again, interesting fact is that there's usually no symptoms. And specifically what I'm talking about is hypertension or high blood pressure. And so often the only times you know blood pressure is high is when you put that blood pressure cuff on and you do the reading and you see that number. But otherwise, patients typically feel quite normal despite what their blood pressure may be. So hypertension, this is a fancy name for high blood pressure and problems with blood pressure. It's long-term an issue. So high blood pressure here and there that's caused for various reasons aren't really the problem that we're concerned about, but it's having this day in and day out, long-standing elevations in blood pressure. And what that does, that pressure really takes a toll on the linings of the arteries, and so it hardens them. And so what usually is a flexible blood vessel, as you can see in the picture here, as the normal with these thinner walls, ends up being a really stiff blood vessel. And so it doesn't tolerate changes easily, and it doesn't sort of flex as need be. And over time, those thick blood vessels can have long-term effects, and it can really hurt the organs where the blood is sort of ending up. So we think about the heart and the brain, but even the kidney and the eyes can be susceptible to high blood pressure. The biggest risk for it is that it can increase cardiovascular disease, heart attack, and stroke risk long-term. So making sense of hypertension or high blood pressure is first, how do we interpret these numbers? So whenever you do a blood pressure reading, you get two numbers. You have the number on the top, which is called the systolic or the SBP, and then you have the bottom number, which is the diastolic or DVP. And the biggest difference between those two numbers is what it's measuring in terms of, did the heart just pump or is the heart taking a break? And that's telling us what the pressures look like between when the heart's pumping and resting. In terms of what is good or what numbers we should be looking for, so in a normal sort of, pick someone out of a crowd, you would say their blood pressure should probably be below 120/80. However, in patients that have risk factors for high blood pressure, they're on medications, they have a history of other cardiovascular diseases, we really say the risk or the goal should be less than 130/80, or in some cases less than 140/90. So that's really the numbers we want to consistently see when we're checking to say someone's not having, at risk for the long-term effects of high blood pressure. In terms of risks in transplant recipients, of course, immunosuppression medications are going to play in. So the same ones we mentioned before, tacrolimus, cyclosporin, prednisone, and sirolimus. Lifestyle choices can be largely impactful. Diet, what someone's drinking, how much salt is in their diet, for example, how much they're exercising. Being overweight can be problematic, as well as having high blood sugars or diabetes. Again, avoiding risk factors is the name of the game. You can also take antihypertension medications to keep numbers in an appropriate place. And then we can adjust transplant medicines as needed if it does seem to be contributing significantly to blood pressure. So moving into our next side effect. This is a side effect that presents as having too much fat in the blood or too many lipids. Who it affects, it's also pretty prevalent. So anywhere between 50 and 80% of adult transplant patients have some abnormalities in their lipid panel. It's also caused by genetics, medications, and lifestyle choices. And very similar to hypertension, there are no symptoms. You don't know you have high cholesterol necessarily until you check your labs. And so this side effect would be high cholesterol. The formal names would be dyslipidemia or hyperlipidemia. So what's the problem with having high cholesterol? So this picture again on the screen, you see those same plaques come into play for atherosclerosis. And what's in those plaques is cholesterols and fats. And so long-term, if you have high levels of LDL cholesterol, it can collect inside the blood vessels and build these atherosclerotic plaques. And what we don't want to do is let those plaques build, collect, and grow, because it does increase the risk of cardiovascular disease, as we've already mentioned. And then just to reiterate that, as those plaques start to get large, it really is the biggest concern, is that we're going to prevent blood from going to the right places and being where it needs to be. So again, let's make sense of these numbers. LDL is also kind of commonly known as the bad cholesterol. This is the cholesterol that forms those nasty plaques within the blood vessel, versus HDL, which is considered the good cholesterol because it helps move cholesterol out of the body. So it helps shift it around and sort of transport it so that it can be excreted. In terms of numbers, I've got sort of the standard listing numbers here. So generally cholesterol overall should be less than 200. We want that bad cholesterol number as low as possible, but really shooting below 100. The more good cholesterol, the better. So anything above 60 is ideal. And then we want triglycerides to be lower as well. Risks in transplant patients, again, the transplant medications we use can certainly increase cholesterol levels in the blood, but so can lifestyle choices, being overweight, and sometimes just genetics can play into this. Avoiding is going to be very similar to things we've already talked about, in that we want to reduce risk factors. So that can be having a low or higher fiber diet, avoiding saturated fats, incorporating more and more healthier fats, omega-3s, for example, exercising more regularly, avoiding fried food, and not smoking. There are also lipid-lowering medications that we can provide, and then we can adjust medications again as needed if this is contributing significantly. And then the last side effect that I will be presenting on is one that presents with elevated blood sugars or elevated blood glucose. Who it affects? So not as common as the other side effects we've talked about so far, but certainly pretty prevalent. So up to 30% of adult transplant patients, so 1 in 3, may have different elevated blood sugars more than we want to see. It can be caused by genetics, of course, medications, and lifestyle choices. And then the common symptoms when blood sugar is out of control is often thought to present with 3 common signs. So the first being increased thirst, increased urination, and increased hunger. And that combination of those 3 things coming together is often a textbook sign that blood sugars are too high. And so, of course, what we're talking about here is diabetes. So diabetes, again, is a fancy name for high blood sugar or high blood glucose. It is common to see directly after transplant when patients are getting really high doses of steroids and things, but that is temporary most often. What we're talking about now is this long-standing blood sugar issue or long-standing elevations. And so 2 names for this can be post-transplant diabetes mellitus or new onset diabetes after transplant. And that would be someone whose blood sugars were normal before transplant and then became elevated and stayed elevated after transplant. The long-term consequences of diabetes are many. So first, it does increase risk for cardiovascular disease. It can cause nerve damage or neuropathies, kidney damage or nephropathies. It can be dangerous for eyes, and it can increase risk for infections as well. So let's make sense of these numbers. So this is probably something you've seen on your child or your own labs. So this number called the A1C or the hemoglobin A1C. And this is really sort of a snapshot into what's been going on inside the body for the past 2 to 3 months. And it tells us how many red blood cells have little sugar particles on them to tell us if the blood sugars have been normal, high, or low. And you can see here there's certain targets. So if blood sugars have been high, the A1C will be high. And this just tells us over the past 2 to 3 months, blood sugars have been in a range that we aren't super thrilled about and that we want to get down. Or it may say everything looks great and we don't need to be concerned. Other blood sugar numbers we see, of course, are the actual blood sugar number. And so this could be what we are checking, you do those finger sticks or you get it with your regular labs. And those numbers can be telling for us based on what time they're being checked. So fasting blood sugar or the blood sugar taken first thing in the morning before breakfast when you've had, 8 or so hours without eating, that will tell us if a patient's blood sugar is in a certain range of goal or not. Preprandial is when someone checks their blood sugar before they eat to see where their blood sugars are before ingesting food and seeing what that does. Postprandial is typically done 2 hours after eating. And then there's also the concept of random blood sugar. So these are all terms you may have heard, but just to know that these are numbers that if blood sugars are elevated, we're going to be asking for to see what kind of the information that we can get to make a good plan in terms of getting on top of blood sugar control if that needs to be done. And so with that, I'm going to pass it off to, one more thing I'll throw in there. So in terms of risk of diabetes, what are we most likely seeing the cause of this being is certainly our immunosuppression medications can do this, probably the 2 most common being tacrolimus and prednisone. Lifestyle choices, of course, being overweight and genetics, and then very similar to everything I've presented thus far is we're going to try to limit those risk factors. There are medications we can use, of course, to control blood sugars. And then if need be, if it's very problematic, we can adjust transplant medicine. Okay, so then with that, I'm going to pass it off to my partner, Jessica, and she can present her set of adverse effects.
Hi, everyone. So we're going to switch gears a little bit, and we're going to focus on some kind of different side effects other than the heart kind of side effects that Mary just went over. Can everyone see me? Yes? Okay. All right. So this side effect presents by either being short in stature or maybe having slowed growth, and that we think of that as height-wise. This affects anywhere from 5 to 40% of our pediatric transplant patients. What causes it usually are long-term steroid use and poor nutrition. So that poor nutrition can, of course, come from just not wanting to eat. So maybe in our cardiac transplant patients, just not having a desire to eat, and then in kind of our liver, short gut patients, maybe not getting adequate nutrition because they're not absorbing food. And this side effect can also affect self-esteem. So what is that side effect? It's growth impairment. So growth impairment, really the biggest thing that we focus on is aimed at decreasing our risk. So before transplant, and this of course is not always possible, we want to make sure we get adequate nutrition with a focus on protein if that's possible, not always with some of our kidney transplant patients. So this really is, making sure that we're, our children or we are getting enough calories and we are growing at an appropriate rate. A lot of centers will have dietitians and nutritionists that can help with this. And then also really just making sure that your physicians are following the growth chart and making sure that you or your child is on a good, basically on the growth chart and you're making progress. After transplant, early detection is key. So if you notice that your child's height hasn't increased at all in several months, that might be something you would want to bring up with your physician, PCP, or transplant physician. Nutrition is also key even after transplant, right? We want to make sure we're again focusing on protein, good quality calories, and getting lots of things that are rich in calcium and vitamin D. If possible, we want to minimize steroids. That's not always possible, we know, with some of our transplant patients, but we do know that that's kind of one of the leading causes of some of this growth impairment. So if possible, we want to minimize steroid exposure. And a lot of our new protocols really focus on minimizing steroids. And then lastly, there is a medication that is available called growth hormone. If you've ever heard of this, it can be a very controversial medication, and especially in the world of pharmacy. This is a subcutaneous injection that can be given anywhere from once a day to there's some weekly formulations that are now on the market. This medication helps, increase the growth velocity that a patient would have and helps kind of catch them in that sweet spot before their growth plates close. So it's definitely something that I would discuss with your doctor or your pharmacist and see kind of if they think growth hormone could be an option for you or your child. Again, this has to be, kind of in that sweet spot. So normally before puberty is when growth hormone is the most indicated. This medication, though, often is very expensive and is not covered under insurance. So definitely your provider can weigh the pros and cons of this therapy. So moving on to our next side effect. So this presents as maybe moles on your skin. It can be lumps and bumps, or it could be lesions. This side effect affects anywhere from 10 to 55% of our transplant patients. The most common cause is immunosuppressants. And fun fact, people with fair skin or light colored eyes and or light hair may also be at increased risk for this. So this side effect is skin cancer. So this is always very scary, but this is definitely something that we like to talk about because early detection is key. So I think there's a whole talk that's going to come up that's going to be with the dermatologist that's going to talk more in detail of this, but we definitely want to go over it because it is a side effect of being on immunosuppressant therapy. So like I said, early detection is key. And so the biggest thing that we can do or we can do for our child or our as a caregiver is really promote sun safety. So sun safety is wearing SPF 50 or higher. I like to say if you're going to be outside for longer than 15 minutes, I always joke that it's really just a good habit to get into all around. We all should be wearing sunscreen most of the time. And our skin will thank us in the future. We'll have less wrinkles, less risk for skin cancer just globally. Protective covering is also important. So that can be a hat or a long sleeve shirt. or staying under an umbrella if you're out in the beach, and then maybe avoiding also peak times. So, we know the sun is the most strong between 11 and 2 p.m. So if possible, if you can go out in the morning, if you're a runner or your child is a runner, go work out in the mornings or in the early evenings, and kind of avoiding those peak sun times. Also, skin checks are really important. So we recommend everyone on immunosuppressant therapy get a skin check with a dermatologist every 1 to 2 years. They will go over this kind of ABCDEs of skin cancer and kind of what to look for. The graphic is on the screen, but what to look for when you're looking kind of at spots on your skin to know if they're abnormal or maybe if they warrant getting a closer look. But again, we do recommend doing yearly skin checks or every other year with a dermatologist. The next side effect that we're going to talk about presents as changes in hair growth, and this can either be loss or growth, like excessive growth of the hair. It affects anywhere from greater than 50% of our transplanted patients. Immunosuppressants are often the causative agent, which is a very common theme with our presentation today. And like some of our other things, this also can affect self-esteem. So this side effect is hair loss or even excessive hair growth, and we're going to tackle both of these. So hair loss, the formal name for it is alopecia. So if you ever hear that, that's the term for hair loss. It's usually associated with tacrolimus and can contribute a lot of times in the teenage population to non-compliance of their medications. So recently in the news a few years ago, Selena Gomez got a kidney transplant and actually wrote an article in Teen Vogue describing the hair loss that she was having from her medications and how that was really damaging not only to her self-esteem, but could, have impacts with her career. So this is definitely something that people experience and can be very scary, and definitely, to a teenager or young adult, this can be something that you would try to avoid at all costs, which could be non-compliance of medications. So, we know we need to take our medications, and that's the most important thing. But if you're experiencing this side effect, you may want to lessen the amount that you take or not take it as frequently because you think that will help. So hair loss is definitely something that hopefully they will also tackle in the next talk. But nutrition is helpful with hair loss. So really that's, focusing again, I keep harping on proteins, but just really good quality nutrition. Vitamin D supplementation also has been linked to decreasing hair loss. So making sure that you get your vitamin D checked at least yearly. And then if you need, putting you or yourself or your child on supplementation if that's warranted. Biotin is something that we get asked a lot of questions about in these kind of hair and nail growth supplements. There's actually really no data that oral biotin helps with hair growth. And so normally it's just not recommended, mainly due to efficacy. And then lastly, you can always discuss this problem with a dermatologist or your transplant provider. They may refer you to a dermatologist, and the dermatologist could recommend something such as a topical product called minoxidil. We know it as Rogaine. This actually has really good data in stimulating hair growth and is relatively safe in our transplant population. The next one is excessive hair growth. So I have a picture here of a little kiddo who you can see where the eyebrows kind of are forming that unibrow. So this is called hypertrichosis is its technical term, or it can be excessive hair growth. This is most commonly caused by cyclosporin, and they actually can use cyclosporin in some formulations to stimulate hair growth, or like I think it's what's in the supplement for your eyelashes to make them grow better. It can present as excessive hair on your face or your body. And really the most important thing to do is to talk with your doctor or consult a dermatologist. So if it's getting to a point where it's bothering you or your child, they would need to talk to you kind of about your options, because it could involve having to switch immunosuppressant therapy, which is always something you want to discuss with your doctor. All right. And the next one is this is actually, I'm so sorry. I'm going to pass it off to Danielle, and she will be joining to talk about the last little bit of side effects.
Thanks, Jessica. Okay, so we are going to kind of switch back a little bit to things that Mary talked about. This is going to present as increasing serum creatinine, protein in the urine, decrease in urine output. Who it affects, it doesn't affect a ton of transplant patients, but it's about 10 to 20%. And what causes it? Kind of like Mary talked about, there are a lot of things that can cause this, genetics, lifestyle, but a lot of our medications can also cause it. And a fun fact is that, it's not really fun, I guess, is it can actually result in another transplant. So this one can kind of sound scary, but what we're talking about here is chronic kidney disease. So chronic kidney disease is basically going to be checked with the glomerular filtration rate. And so the numbers that you guys are going to see here often in your labs are going to be that serum creatinine number. What you guys might also see, some of the centers are checking cystatin Cs now. And unfortunately, most of our results are not calculated to do these equations for our pediatric patients. A lot of them are just geared for adults. So a really good resource is to just go into Google and just Google pediatric GFR calculator. The National Kidney Foundation has one that lets you add in that creatinine and a little bit about your child's information. And then if you happen to have a cystatin C, you can throw that in there as well, and it'll give you a result of what that GFR means or what that GFR calculates to be. So what we know then is that GFR, as you can see in this picture, is broken down into different stages of chronic kidney disease. And so this is important for you all to kind of keep track with and know about as you're going forward with your transplants. The risks associated with this for our kidney transplant patients in particular are going to be medications. You guys probably all remember the day you learned that tacrolimus and cyclosporin can cause kidney damage, especially for our kidney transplant families. That's always such a bummer to learn that. Some of our other transplant patients are also going to be exposed to a lot of antibiotics that can cause kidney damage. There are some antifungals that can do this and some antivirals. So if you have a situation of, especially if your child has had sepsis and they've been exposed to some of these antibiotics, that can do a little damage to the kidney. We also know that previous episodes of acute kidney injury, especially around the time of transplants, there are just some things that happen in the OR and around surgery that can put a little extra stress on the kidneys as well. Tying back to the things we talked about with diabetes and the cholesterol are going to be your lifestyle choices. Those are very important factors that can increase the risk of kidney disease as well. Poor diet, lack of exercise, obesity, poor genetics, or unfortunate genetics, I should say, are also risks. How to manage? There is a theme with all of this, and that's going to be prevention, avoiding risk factors. So helping your child not smoke, helping them not gain a lot of weight, and keeping their blood sugar under control. Healthy diet is actually found to be very, very helpful. I know my dietitians would love it to hear me say that because I'm the pickiest eater in the world, but fruits and vegetables are great for your kidneys. So if you can get your kids to try and eat a healthy diet as much as possible, that would really help them with managing kidney disease. And then just really identifying that it's happening and intervening with your medical team can help you with looking at this. So the reason why I'm stressing so much the talking to your medical team and looking into this so much is because there are medications to delay progression. So you can see in this graph over on the other side that there is a straight line down in a constant decline of kidney function, and everyone's on their own trajectory. So what you can see is that the sooner on that chart that you can offer treatment, early treatment, you can change things by about 4 years before the GFR gets into that kidney failure range. So the sooner you can do that, the more life you can get out of the kidney. And this is all stuff that you would definitely want to be talking to your transplant team about, but it helps, I think, for you all to know these things exist, and you can ask questions about them, like, is it appropriate for my child to maybe start on an ACE inhibitor or an ARB? So these are your medicines like lisinopril, enalapril, losartan, or maybe your child's already on those medicines and you can know and have the knowledge that, oh, this is helping protect their kidney function. SGLT inhibitors, this is, I said new because for us in pediatrics, they are very new. They are actually not that new to the adult world though. They've been around for a little bit. They're only approved in the 18-year-old and over population, so your adult transplant programs are going to be more involved in using them. But the really cool thing that's coming out about those drugs, which were approved for use in diabetes, is that they're actually finding that they're improving kidney and cardiovascular outcomes. So hopefully in the next couple of years, we're going to have a lot more information about this in the pediatric population so that we can have another drug that's going to help with our progression. The other thing you can talk about with your transplant team is there a way to change the immunosuppression? There's some other medicines out there like the belatacept infusions. That's a possibility to maybe come off of the cyclosporin or the tacrolimus. And then some programs might do an mTOR inhibitor like everolimus or sirolimus. Some places will swap out the tacro and the cyclosporin, or they'll maybe be able to run those levels a little bit low in addition to the mTOR inhibitors. And again, very dependent on the type of transplant you have. So it's really important to talk to your transplant team, but I think it's helpful to know that there are some options. I'm going to switch gears here a little bit, and I want you all to look at this brain because I think that this picture is very descriptive of what we see in our teenagers. So a side effect of just life is that our kids are going to get older and they're going to become teenagers. You see right there in the middle, there's a big little word that says drugs. Those aren't our drugs, unfortunately. I wish that that was medicines and that was, oh, I really need to take my medicines and that this is really important. But there's a lot that comes with being a teenager and brain development. And so the next couple of things I'm going to talk about are not exactly side effects of medications. They're just complications of kind of life. And then we have our medicines that aren't necessarily helping things. So the first one I am calling now a complication, not a side effect, is it presents as anxiety, sadness, hopelessness, decreased energy, lost interest in hobbies. Who it affects? It affects up to 60% of our transplant patients within the first 2 years of transplant. What causes it? Medical complications, rejection, pressure from the medical team or parents, lack of having a support system, and then actually 280 million people currently suffer from this in the world. And this is, of course, depression. So depression is something that a lot of us as adults have maybe experienced. In transplant patients, what we know is that kids of all ages, we know data up from 3 and up, can be affected by depression. So it's mainly associated with a prolonged hospital stay. If there's been medical complications that, are just occurring, even the outpatient setting, we know that that can really cause some stress to the patient's life and the family's life. It's also associated with episodes of rejection. That can be a really stressful time. Anytime there's a big significant life change for your child, if there's been a death in the family or a move, those things can really, cause issues. And then getting a transplant in itself, that's a big life change. And then there's also some thought that maybe high-dose steroids can contribute to depression. We do know steroids lower serotonin, and serotonin is what helps kind of keep us happy. So if we're using a medicine that's lowering that, it's maybe setting these kids up for more issues. Why this matters, people who are depressed tend to have longer hospital stays. They also have a decreased quality of life. They may have an increased risk of rejection. They do tend to participate in more high-risk behaviors, so this can be a big deal with drug and alcohol abuse. They're also more likely to smoke. We can have suicidal ideation, which, as we know in our teenage population in general, is a really high risk. So it really matters. And then in our transplant situation, it matters because it also might be linked with medication non-adherence, and that would be a big deal too. So what can you do? There are a lot of things to treat depression. and you guys have probably heard all this even as adults, right? We have lots of options. All the things also apply to children as well. Medications are always an option. Talking, also very good options. And what I found in doing this talk is that, Mary, if you'll click next slide, or next click, there's a website on the CDC that's actually geared all towards children's mental health. It has a lot of really good resources for parents on there about just understanding mental health and what can you do, and just tips and tricks for parents. It's a very overwhelming, kind of scary thing to think about your children's mental health not being well. So I highly recommend looking at that if you guys are just looking for a place to just start searching for some things. And then next click, Mary. These are just some tips that come with trying to help your children, not get depressed. So trying to teach and build resiliency in them, making sure that they have a strong support system around them, and then don't ignore early warning signs. If you're worried, you can talk to your transplant team and they can help get you, where you need to be. Remember, the transplant group is multifactorial. You're going to have resources there within the transplant program with your social workers and your psychologists. And then they're also going to know and be able to help kind of set you up with people who know how to talk to children who are going through what they're going through. And don't be afraid to seek out help. This is a really important piece of just disease management that our children and parents need to be aware of and try to step in and help with. So the next complication is going to be presenting as variation in drug levels, graft dysfunction or rejection, who it affects up to 60% of any patient in the world who's prescribed a medicine. That's who this affects. What causes it? Immaturity, lack of knowledge, medical complexity, and it may contribute to graft failure. So this is medication non-adherence. I'm realizing now that I have really all the fun things to talk about. These all sound really scary, but medication non-adherence is a complication that we see after transplant. What we think causes it is that a whole bunch of different things. So it's not necessarily that kids or adults are intentionally forgetting to take their medicines, but often there are side effects that they're playing a role that makes them not want to take their medicines, so then they're less likely to remember to take them. Things that are more complex, we know, make it harder to take medicines appropriately. So if it's 3 times a day on an empty stomach and then you have to take something 2 times a day with food, that just makes things harder. We do know that some people just have a belief, no matter how much you try to tell them, that, well, I just don't need this. This is a silly medicine. I don't need to be on this medicine. Sometimes you just plain old forget. Sometimes, and I'm sure every transplant parent has experienced this, you have logistical issues. There's a problem at the pharmacy, they're out of stock, your mail order delivery didn't come, and you just don't have the medicine. And then there's a cost barrier. Hopefully most of our children are able to get the medicines they need with all of the resources we have in place. But as they get older, and age into the adult programs, cost often becomes a big issue. And even for some of our, children with private insurance, those numbers can add up. And so it can be a big deal how expensive these medications can be. So ways to improve medication non-adherence. The biggest thing that people try to do is just to repeatedly educate. Get buy-in from the families and the children. Why is this important? Why do you need to do this? Your support from medical team is really important. We all want to have honest conversations. We're going to be there to offer encouragement. We're going to be there to talk through whatever challenges you're having. And most of the programs actually are willing to change things if that will help. If you're having side effects, we can talk about an option. If the medication regimen is too complicated, we can try to simplify it. We can definitely help. Other ways to help are support from family and friends. So friends reminding your child to take their medicine when they go out, at night to see a movie, something like that. It makes a big difference when you have that extra support. Behavior therapy is, again, always an option too, especially within your transplant programs. You might have very specific psychologists or specialists, social workers who specialize in adherence therapy for kids with chronic disease. You can also have a bunch of different reminder systems. I did some Googling on this, and I was actually kind of amazed at how many new devices are out there for things that spit out pills at you, that beep at you, alarm at you, that are giant, that are small, that are portable. It was kind of crazy. So find a device that works, that you like. Have your kid maybe take a look at what's online and see if they find one that they like and that they'd be willing to use. There's a bunch of phone applications you can download on your phone to try and help you remember. Pill boxes are a good classic way. There's, again, really fancy pill boxes now that will alarm and whistle at you. And then there's the classic, just pair it with a routine. So as soon as you get up in the morning, or when you brush your teeth, or when you eat dinner, that kind of stuff always is helpful too. And then sometimes you can, if you're not locked into a pharmacy, which I know a lot of people are these days, but you can, if you have the ability to shop around for a pharmacy, you might be able to find one that actually packages pills, the whole day's pills, into a packet where you can have like a 9 a.m. packet, a 1 p.m. packet, and a 9 p.m. packet. You can also look into auto refills if you struggle with remembering to get things refilled. You can get a 90-day supply. Or find a pharmacy that is easy for you to do your ordering, your pickup, and your delivery. And so, kind of going back to the question of what does the future look like for our kids? Well, really, ultimately, all of our kids are going to be adults. So the future for our children is that we're going to be eventually getting out of the pediatric care model, and we're going to be transitioning them into the adult care model. So that's the real future. And I know there's a talk later today about transitions of care, which is going to hopefully provide you all with a lot of information. But I wanted to share this picture. I thought it was really good to kind of show that at a young age, so on this picture, it starts at 12, you can start building self-management skills as you're learning your health. And then you can see that you have family with a dependent youth, and then you're trying to help your youth gain a little bit of independence, but you're still there. And then as you're transitioning into a developing adult, at the age of 21, 22, that's when you're starting to kind of let your child have more independence, and you're allowing them to go into like an adult care model where they can then be an interdependent adult, and use social supports around them. And so the other thing that we just wanted to kind of share with you all is that there's a bunch of things you can be doing to try and help prepare your child as they're getting ready to become adults, and that can start at any age. And then in your transplant team will likely have a list of topics too that they're trying to think of to cover. But in a lot of programs are trying to work on this. I know our program in particular, we've kind of outlined very similar things, a whole bunch of different like topics and check boxes that we have to check now. And so these are just some example topics that we are trying to make sure that all of our transplant patients are seeing and being exposed to, and that's making sure they have a good understanding of their transplant, making sure they understand their medicines, have good medication knowledge, understand why they have to be adherent to their medicines and their lab work, understand what risk-taking behaviors are and why they shouldn't be participating in them, how to stay healthy, how to be an advocate for themselves, how to stay safe from a reproductive side effect, and when can they have children, what do they need to do to not have children, those type of things, how they can manage school and or work, why self-esteem is important, what health insurance means, and all those fun things that come with health insurance, what is an advance directive, learning more of those complicated things that come within healthcare systems, and then how to identify a support system. And those are all really important topics for kids to learn. And with that, I'm going to close out and leave it open for questions.
Thank you very much for the presentations. We do have a few questions that have come in. Two of them are fairly similar, so I'll ask them together. So Tracy Lee asked, per Mary's slide, is the risk of cardiovascular disease 1 out of 2 for adults only on immunosuppressant, and what about pediatric transplant patients? And then Christina asks a similar question. Can you clarify if the data presented mainly applies to adult transplants?
So in terms of cardiovascular disease, there isn't really a lot of data in children because it takes several years for that cardiovascular disease to present itself. So what we really have to think about now is what are we doing during childhood, adolescence, building up to that risk factor, but really it's not until patients become adults that we're seeing the cardiovascular risk. So the data is in adults, and so it seems to be in adults who have transplants. It's about 50%, so 1 in 2 that have some cardiovascular disease, as compared to the 1 in 3 who don't have transplants. But of course, being a younger patient, being on these medications, having these risk factors over time, if we aren't keeping those risk factors in check, can certainly increase that risk and add up to a greater risk of cardiovascular disease as they, are older adults, leading adult lives.
Okay, thank you. And then Bonnie asks, are heart transplant recipient candidates, are heart transplant recipients candidates to receive growth hormone?
So yeah, so there's actually really good data. Most of the data is in kidney transplant patients with the safety of growth hormone in combination with a transplant, but it appears to be safe and really doesn't have any adverse effects. This is something though that you really do need to discuss with your doctor about the risk versus benefit of the drug. And like I said, it is very expensive, and most insurance companies don't cover it. So it could be an added cost of several thousands of dollars sometimes for patients. So, but yes, from a drug standpoint with your immunosuppressant, there is no interaction and can be used safely.
Okay, and then finally, with the legalization of CBD and marijuana, it's becoming more saturated into even teens' life, and they see it as similar as just smoking. And is there anything, any evidence that can be given to transplant recipients as they try to make that decision on whether they try or not try these things like gummies?
I can take a stab at it. So especially because I was living in Colorado before, so this came up a lot as its recreational use is legal. So there's a couple of things to think about with marijuana. So we do know it can interact with medications. So specifically, if someone's taking tacrolimus, we know it can affect their tacrolimus levels. So there are concerns from that perspective. Obviously, the data is not plentiful because we're not doing randomized control trials of people using drugs. But we do worry about that. I think the biggest concern is more in line with the fact that we don't always know what's in those products. So yes, in some states there are, dispensaries that are more regulated, but we still don't fully know what's being used in those products, if there's additives. And so just like any other herbal supplement we tell our patients to be cautious with is we don't want you to put anything into your body that's going to negatively affect your transplant or any other organs. And so with marijuana, there's a lot of unknowns. It's not, FDA regulated and what have you. It also is a matter of how you use it. So for gummies, the risk is much lower, right, in terms of what kinds of infections and things you can get because the stomach's pretty intact. If there is a bacteria, your stomach acid can certainly probably manage it. Versus smoking marijuana or vaping, anything like that, can really expose the lungs to infectious materials or other, chemicals that can cause lung damage. And so we almost sort of the experience that I've had is we obviously don't encourage anything that's illegal, but kids will be kids, adults will be adults, people will do the things they're going to do. And so we want to be responsible about it. Smoking is never going to be recommended by the transplant team, either it be a cigarette, marijuana, vaping, what have you, because it's just high risk from a cardiovascular perspective, from an infection perspective. There's so many reasons to not do it. So CBD type products, gummies and things of those natures. For some people, they can be beneficial. We know it can be helpful with pain. We know it can be helpful with nausea, appetite stimulation. So in sort of controlled settings where your transplant team knows what you're doing, maybe you're in a state where you can get it from a regulated dispensary and you treat it like a medicine. So you go to the same place, you use the same doses, you're kind of treating it in a more controlled fashion than just, I'm going to go to a party and eat a brownie type of scenario. It's something that we can control and account for when we adjust drug levels, and we're monitoring you knowing that we need to be thinking about that. So I don't want to say the answer is absolutely no, but I think there are instances when it can be done, and it can be done relatively safely, but we do overall discourage illicit drug use and, of course, in smoking anything.
Okay, and then we have a question. I hope I don't butcher the name, Sridevi. Is early detection the key for diabetes side effects? And if so, is it reversible?
Sure, yes. So I know it can be scary if you get the diagnosis of diabetes, and it really is based on those numbers. So we look at blood sugars. We're checking them every time a patient gets their blood sugars drawn. We look to see what the glucose is on that, with that reading, just like we're looking at the serum creatinine, we're looking at the tacrolimus levels. So we're always watching it. If we see it gets high, we certainly want to intervene. But in many instances, diabetes can be managed and potentially reversible in that they don't need diabetes medications long-term if we take care of the cause. So if this is someone who's going to have diabetes potentially because of family history, genetics, that may be out of our control. But if it's because certain medications are increasing blood sugars or dietary choices are happening, we certainly can work with the patient to limit those and work towards getting off of therapies, or at least have them on therapies and have things well controlled.
Okay, and we have one last question from Miguel. How do we get an early diagnosis of cancer in a post-transplant child?
Is this just a diagnosis of like just any type of cancer, or are we talking like skin cancer? Maybe, I don't know if Miguel will clarify.
I don't know.
I think this goes a lot with what Mary was saying, right? So the transplant team, we as a team are very, cautious, and we're also very good at our monitoring and making sure we're monitoring at appropriate intervals. So, you are predisposed to certain types of cancers or malignancies post-transplant, but that is something that the transplant team is very good about watching out for. So some early detectors would be lab work and kind of some things like that. Always, if you or your child or whoever had the transplant is experiencing any symptom, I always tell people, always call, right? So if something's odd or not acting the same or usual, or you just feel off, always good to get in touch. But this is something, kind of these long-term risk factors that we are monitoring for pretty closely, and kind of can detect early warning signs. If you're specifically talking about skin cancer, really the best thing is, to do kind of your own skin checks, or whoever is the transplanted person, do a skin check every month or two, and just kind of go over your body, look at the moles you have, kind of look at your freckles, see if there's any changes. And then if anything changes, always consult a dermatologist, and then to really make sure you stay on top of your yearly or every other year skin checks with a dermatologist. Anyone else have anything to add?
We do have one more question, and then the session will end. So this is from Tracy Lee. She says, it sounds like cyclosporin is such a catch-22 immunosuppressant drug. Is that one of the most effective yet highest risk of other side effect drugs out there? In other words, are there highest to lowest amount of side effects tier level amongst all immunosuppressant drugs?
Danielle, you want to take that?
Yeah, I can take a stab at that one. I would say yes. I mean, I think, and this might be a different answer among all of us, honestly. I think different programs handle this differently in that, the reason most programs use tacrolimus as first line is because cyclosporin does come with the most side effects. That being said, if there are indications or reasons to switch to cyclosporin, most of the programs will make that switch. It's always a matter of risk and benefit, and everyone is going to respond a little differently. So what might seem like the highest side effects might not actually affect one person as much as they affect another person. And I think that's true, really for all of our classes. I think a lot of us also feel like sirolimus has a little bit more side effects than everolimus. So everolimus is gaining favor with a lot of transplant programs, but there are a lot of people who do just fine on sirolimus. So really it's all a risk benefit. But I would say for sure the reason cyclosporin is kind of considered like the old drug is because of the side effects, and tacrolimus has then kind of taken its place because of that. I don't know if you guys have anything else to add. Great, Jessica.
Yeah, I think that's one of the biggest challenges in transplant is we know these medications are necessary, lifelong, and they are so beneficial for the transplant, but they certainly come along with these side effects. But it doesn't mean the side effects happen to everyone, and we know how to work around them. And so, yes, they come with them, and we know that that's an option, and we're always monitoring for it. But for the most part, the majority of patients tolerate these things fine, and don't have all of these things that we've gone through. So we certainly don't want to scare everyone. We just really wanted to more so put it out there so you're equipped with the information and empowered with it, but we don't want you to fear the medicines.
All right, we have gone over a few minutes, and so I wanted to thank our presenters very much for their generous time, and we will end this session so people can jump into the next session. Thank you.
Thank you.